If you touch, so if it gets on surfaces and you happen to be eating at that surface or touching that surface or touch your face or whatever, that was always the concern, is that it might be about of transmission. And especially if you're in a hospital setting where, you're going to have a lot of people perhaps sick with coronavirus. And if you're touching those surfaces and, kids are putting it to their mouth or whatever, that could be a route of transmission. But this is probably accounts for most of the transmission we've seen of SARS-CoV-2. Now, aerosolized droplets can carry very far, and maybe some of you guys saw the things on YouTube where you'll see a supermarket and somebody coughs and 4 miles away, these aerosolized droplets. Well, that is a route of transmission. It's not the major route, but it can be transmitted, and those can carry quite far. And that's, of course, impacted having things open like the synagogue, because, even if somebody is trying to do social distancing, that coughing, that aerosolizing can really actually have these droplets carry quite far. In the beginning, you got probably not the best advice on mask wearing, but wearing a mask here and wearing a mask here cuts down the transmission by 95%. Of course, wearing the mask properly over your nose and your mouth. There might be some transmission that goes on if you get coughed in the eyes and stuff like that too. It's basically wherever these ACE2 receptors are in your body, that's where the virus is going to bind and enter. Risk factors for severe COVID. Now, this is the key thing, is severe COVID is what we worry about. And these are the folks that are really the ones who are at risk for severe COVID. And severe COVID is where people really are what we call hypoxic, where their oxygen levels are very low. And I have to tell you one thing about COVID, it's a very strange hypoxia, because I've seen people where their oxygen level, normally your oxygen level is about 95%. For a healthy individual, it's more than 95% when you measure on that little pulse oximeter. I've seen people in front of me where their oxygen levels are like 70%, which is someone like, in the throes of, if you had put in it, like a severe asthma attack. And they're talking and they're comfortable, and it's amazing because, and it's amazing that they're that comfortable, but there's a dissociation of their feeling of the hypoxia and just how low their oxygen levels really are. And one of the things that we had in the hospital that happened was people would have their oxygen, their nasal cannula on, getting oxygen through it, and then in the middle of the night would take it off and go to the bathroom, and the nurse would, find them, unfortunately, in either respiratory distress or dead on the floor, because they didn't understand just how low their oxygen was, and they had a major, respiratory event. So looking at who gets really severe COVID, and this is not the 100% list, we've seen very healthy individuals end up with severe COVID, which is really the oxygen levels that are quite low, under 94%. Older age, people have pre-existing chronic obstructive pulmonary disease. We used to call it emphysema or emphysema-like diseases, or severe asthma, cardiac disease, type 2 diabetes, obesity. We saw so many young individuals who their only risk factor for having severe COVID was that they were obese, BMI being more than 30. BMI is a measure of your height to your weight and what you should be. And honestly, it was very difficult to take care of them, and we lost quite a few because it becomes very difficult to manage their airways, their breathing. And one of the things we did with COVID is that we had to put people in prone position, which means on their stomach, and bang on their backs to really kind of loosen up some of the phlegm and help them with breathing. It's not so easy to turn people when they weigh 400, 500, 600 pounds and they have a very highly infectious disease. Sickle cell, chronic kidney disease, immunocompromised state from solid organ transplants, cancer, hepatitis B, pregnancy. Pregnancy by itself is an immune compromised state. It's not always appreciated as such. But these are all the folks that really are at high risk for having bad outcomes if they get COVID. We've seen a disproportionate burden of COVID-19 among racial and ethnic minorities, Native Americans, and the indigent. And a lot of this has got to do with really, social structure and inequities. But, folks living in crowded housing, if you have one person who gets COVID and you have people 4 or 5, 10 people maybe in one household, you can imagine, especially if it's a person who comes in who has minimum symptoms or no symptoms, they can infect the whole household. And those households usually are very diverse in terms of age and in terms of health conditions. So you really can spread very quickly. And we had apartment buildings in the Bronx where entire buildings would have people with COVID, and it would be overwhelmed in that March and April surge that we had. And you can see, really, sort of how this is a disease that really preys on folks indoor living and crowded living. COVID-19 can have mild to severe symptoms. So the symptoms that we see most commonly can be fever, cough, shortness of breath, commonly also sore throat, runny or stuffy nose, body aches, headaches, chills, fatigue, GI, diarrhea, nausea, loss of smell and taste. The Indian variant, they're not calling it that because they say they don't want to have it be racially or ethnically associated with one country. They're calling it the Delta variant. It seems to be much more of a GI related presentation, diarrhea and nausea. I almost could tell who had COVID on the phone at a certain point because there would be a certain kind of almost like metallic kind of sound to their voice. And then you would ask them, do you have a sense of smell or taste or disruption of those? And, and invariably, they'd say, oh yeah, it's I can't smell very well for the last few days. And, and especially before we had COVID testing, it would be like, okay, this is the real thing. And, do your best to stay away from your family. But again, a lot of the patients I take care of share a household, an apartment with 9 or 10 people. And so how do you isolate when you're in that kind of a crowded situation? And it wasn't until much later that even, trying to have people have accommodations made by the departments of health was really in place. So they couldn't go to a COVID, isolation area, a COVID hotel. Severe symptoms, trouble breathing, persistent pain, or chest pressure. I'm sorry, that's a typo. New confusion, especially in the elderly. This might be just the presentation that an elderly person has with COVID, that they're much more confused than usual, and they may not have much else. Inability to wake or stay awake, pale grue or blue colored skin, lips, or nail beds, depending on skin tone. Now, this is really someone who's hypoxic. This is somebody, that's a really bad sign if they come in looking like that. We had so many patients who would present with mild illness, and we were trying to manage the best we could in the beginning, and we were so unprepared. And, we tell them, go home, stay in touch with us. And sometimes within 24 hours, they would have progressed from here to severe symptoms and sometimes even died in that short amount of time or really been in bad shape. I'm not going to go through all these, but you can see that COVID really can hit lots of different parts of the body, cause lots of different impact on lots of different things in their organ systems. Lungs, liver, brain, everything could really be involved with COVID. And, we saw, plenty of patients developing blood clots who didn't have blood clots before. So it's a really kind of hits a lot of different things here in the body. Just to give you an idea, this is a CAT scan. So this is like if you cut somebody, maybe sort of in the mid chest, and we're looking straight downwards. But you might see, so this is my wife's listening in, she's the radiologist, so I don't try to pretend, but these should be nice, clear black. The black is good, that's air. And some nice clear spaces. And what you get with COVID is you get this, what they call ground glass appearance, all in the outer parts of the lung here. So we see all these kind of areas of what we call opacities or consolidation occurring all throughout the lungs. And that's, but they looks more rounded than we see with a lot of other infections too. COVID, it causes the blood clots, problems with circulation, especially in the small areas of circulation. So people sometimes, come in there with COVID toes, they would call it chilblains. They have these little purple spots on their toes or fingers. Really? Yeah. So, that could be the presentation just there, I'm having the cough and the cold and I have these painful toes or this discoloration of my toes. Again, COVID can hit lots of different parts of the body, but these are the ones that really cause us to have trouble. Things that affect, of course, the major organs like the heart, the liver, the kidneys, and the lungs. Everything from a myocarditis, and it looks like some of this myocarditis is an inflammatory reaction. COVID itself causes the infection in the beginning, but then about a week, 10 days in, the body makes this strange, very vigorous, inflammatory, out of control reaction. And that out of control reaction is affecting different organ systems. And that's, why we know sort of in the beginning, we're treating with these monoclonal antibodies. We're trying to cut down on what we call the viral burden, but we're trying to avoid this part of the course of the disease when we flip from an infection to really an inflammatory reaction by the body. And it seems this inflammatory reaction is especially intense in all those folks that we talked about before: old age, cancer, obese. These are all diabetes. These are all conditions that already are people prone for hyperinflammatory states. And then this COVID really seems to kick them over in day 12. I had one woman really, her wrists, I take care of folks with HIV. Her HIV was in good shape, but she was obese. She is obese. And she had her high blood pressure, which was controlled. She called me up on a Thursday. She was working as a custodian in one of the office buildings in Manhattan. Doc, I don't feel well, whatever. And this is in March again, that third week in March. I don't feel well. And I said, oh boy, this is going to be COVID. And what if I stay in touch with me, go home, rest? This is what we had back then. The next day, she didn't call me. Her daughter called me. Mom's not breathing. I called EMS. 911 got there. They intubated her in the field. They brought her in. She was in bad shape. She was ventilated. She spent 3-4 weeks in the ICU. We were just starting out doing lots of the early studies on different therapies. I'll take you through some of those therapies. But the therapies we were doing were Remdesivir, which is a medication that actually works as an antiviral, and another medication which was really trying to stop this inflammatory state. We gave her whatever we could. We had to sign up through an informed procedures, formed the consent research protocol. Her daughter had to sign for those because she was intubated. She couldn't sign for them. She was in the hospital a good 3-4 months. She developed, unfortunately, thrombosis. She lost both her legs. She had to have bilateral amputations of her legs because she got clots and then became gangrenous. So she eventually, more than 6 months later, finally was extubated. She's been in a rehab center in New York, and now she's fit with prostheses and trying to learn how to use them and walk again. But devastating in the early 50s, and that's how fast it happened. I know you guys are not pathologists, whatever, but this, I felt, just to try to give you an idea of what it is when they talk about these things on TV. This is what COVID looks like. This shouldn't be here. This is all inflammatory cells and thrombi, what we call clots or thrombi, that are formed. And this is what it looks like in the lungs. None of this should be here. You shouldn't be seeing this level of inflammation, and you shouldn't be seeing all this damage to the lungs. All these dark things, these are inflammatory cells. These are what they call lymphocytes. And it's really invaded the lungs, and you're getting blood clots there too. So none of that should be there. I'm not going to talk too much about post-COVID syndrome, but this is the other part of it, is that people get better. Sometimes they didn't even have much in terms of COVID, and then they have this ongoing syndrome where they get brain fog, can't think clearly anymore. Sometimes I feel like this at the end of the day, but this is what people feel like with COVID. Fatigued, just this overwhelming fatigue. I have a good friend, he was my college roommate. He's a South African Jewish guy. And if you guys want to Google in New York Times, COVID and family gathering in Connecticut in March, his family had a whole gathering when COVID started, right when we had Bobo Beater's celebration at the temple, right at the same time. They didn't hug each other. One of the family members was going back to South Africa, so they had a going away party. No one got close together. They elbow bumped and all that stuff, but weren't wearing masks like we were wearing at Bob Obita's going away celebration. Well, the person going back to South Africa unfortunately had COVID, didn't have much in terms of symptoms. There was about 30 people at that party. They all got COVID. By luck or chance, my friend, he wasn't out there, but all his cousins, his uncles, his aunts, they were all there. They all got sick. Most of them ended up in the hospital. Thank God no one died. They did get better, but many had these ongoing cognitive difficulties months and months and months after, and they would call me. I can't get out of bed. I'm so tired. I have good days. I have bad days. Some days I can't think straight. I have these headaches, weird dreams, shortness of breath. My heart feels like it's pounding. Just all these kind of things. And they were, they were all infected at that party. We don't have great guidance what to do for it. There's these post-COVID and long hauler clinics, and the CDC has some recommendations, but I can't tell you there's a go-to, this is gonna fix it. We do see these post-viral syndromes with other things too. It's people who've had mono, people who have even had flu, they can have long-acting kind of things that go on afterwards. So it's not COVID, that's the only thing that has it. It's probably some kind of immunologic-related problem, but we really don't have a handle on what to do when people have it besides just this supportive care, to give them when they feel short of breath, use an inhaler, headache, just treat the symptoms, but we don't have a go-to thing. It does seem to go away with more time. And there are anecdotes reported of people who got vaccinated, who had these long hauler syndromes, and they got better. And so maybe they have a more broad-based immune response after the vaccination that leads to better control of whatever these symptoms are being caused by, but we still don't know enough about it. Again, I don't expect you guys to be experts on all this stuff, but just to show you just what some of these numbers are and what people talk about and what is going on. We talk about a reproduction number with viruses. And what that means is that one person who has flu can really spread it to 1.5 people. That's sort of can spread in. COVID and maybe even some of these variants that are highly transmissible can spread to much more. It's usually between 2 to 5 people, that we're seeing with COVID-19. SARS also was 2 to 5. MERS was even worse. And you can see how many people can be infected from one person with measles. So, when we think about where we are now, vaccinating, herd immunity, that kind of thing, but we're also seeing the pockets of people who are not taking the vaccine, for whatever reason. Well, those little pockets, if you have, and I see this happen, it seems like a whole group, family that doesn't get vaccinated. Well, those little pockets, that one person can spread it to that whole group of family very quickly. And as we progress here, and we're vaccinated and we're getting back to a more normal life, people are going to take their mask off, and you're not going to know if people are vaccinated or not vaccinated in many of our casual settings. So that's the concern, is that, this one person here can really spread it to quite a few people and they can all get sick. And that's what we saw too in the hospitals. One person would come in, we tell them to go home, and the next day, 3 or 4 family members were coming in. Just to give you an idea, where COVID stands in terms of these things, we're just hitting now, unfortunately, a milestone of 600,000 US deaths. The flu pandemic in 1918, fatalities globally was between 40 and 100 million. In the 1957 flu epidemic was 2 million, 1968 was 1 million. New York Times, this is from last week, I didn't have the updated, but globally now, cases, and this is going to be underreported because we didn't test all these people, but 175 million people probably, at least. That's really an underestimate. And you can see the peaks that have gone through globally. And South America is now getting whacked pretty hard there, Argentina especially. Deaths worldwide, and again, this is probably a underrepresentation, but at least 3,750,000, but it's probably orders of magnitude higher than that. So this has been really quite a challenge worldwide. And then mortality, you can see, how this disease really goes up as you enter into the later decades of life. 50 to 59, 1.3% mortality, but as you get to 70 to 79, 80 plus. Thank God, we've done a good job nationally getting those over age 70 vaccinated. And if you look at the New York Times, you can just put in Google New York Times COVID tracker. I always look at that one. You can see where we are in terms of vaccinations, infections, but over 70, we're doing pretty well getting people vaccinated. And that's really important because that's the group that's hardest hit. The group that's not so willing to get vaccinated is the 40 to 59-year-olds. And that's where we're seeing COVID cases. And again, if you have those risk factors like obesity, diabetes, whatever, it's no joke. Those are the folks that are getting sick. How do you manage an epidemic? Well, you guys have lived through a lot of stuff. You wear a mask, and you got to listen to the CDC when the CDC is actually giving true advice, not being politically influenced. Mitigation, wash your hands, cover your cough, stay away if you feel sick, avoid touching your face. We've gone through all these things, social distancing and not having rallies and gatherings and, indoor activities, cleaning surfaces. You might remember we were talking about, we got to flatten the curve. We got to get there. And we learned the hard way of what happens when you don't flatten the curve. When you don't have to flatten the curve, you're going to go through this huge peak. And I'm going to come back to what herd immunity means, but this idea that we were going to get through herd immunity by infections, yeah, at what cost? I mean, a disease that has 1 to 2% mortality, and you're going to have herd immunity, which is going to be, infections of, more than 70% of the U.S. population. That's going to be millions and millions of deaths. That's crazy. It's a crazy way to approach this. But this is where we stand now. It's a little bit better. We're 42% fully vaccinated. People who've gotten either the J&J 1-shot or the 2-shot mRNA vaccines in the US. And 52% have gotten at least 1 dose. You're probably about 80% protect after that 1 dose, but the durability comes when you get the 2nd dose of the mRNA vaccines. And we'll come back to it, how durable those are. But the thing is, you want to vaccinate when you're a flat curve. You don't want to vaccinate when you've had so many people sick and getting constantly infected, like playing catch up, but unfortunately it's going on now in India and other parts that are hit so hard. This just gives you a time course of what's going on in terms of infections. In the beginning, the virus is replicating. Your body makes an immune response about a week to 10 days in, makes this intense immune response. So when they kind of plan out where to treat people, antibody therapy, viral replication, we want to hit it with the antivirals early. Those antivirals probably work best in the first 7 days of infection. And we really only have 1 antiviral right now that's approved, Remdesivir. There's a few others that look good. And I think that'll be helpful because if people don't get vaccinated, we want to have therapies that we can still use for them. This gives you an idea when we talk about disease. Moderate, mild disease really means that your oxygen saturation is above 94% on that pulse oximeter. The symptoms are mild. They really basically are not impairing your breathing. Severe illness means that your respiratory status now is compromised. You're breathing pretty fast. Usually you're breathing about 16 breaths a minute. This is 30. You have infiltrates on the lung x-ray or the CAT scan, and your oxygen saturations drop below that 94%. And then critical illness is when your organs start to fail. So that's really sort of an idea of what that is. We call about virus life cycle. Virus life cycle means, again, they're not living, but the virus goes through steps. It's a bunch of proteins, fat, and directions on how to make virus. That's what viruses are. And it recognizes this ACE2 receptor. But each of these steps is also a place where maybe medications can actually interfere with virus making more virus. Coronavirus brings in a positive strand RNA. What that means is that it's primed and ready. It's got the instructions in there. It's just got to get in that cell through the receptor, and then the instructions are really ready, and your cells are going to take that what we call positive strand RNA and start turning it into proteins. And then coronavirus has like a scissor, we call it a protease, that cuts those proteins into the functional units to make the baby viruses. But all these steps can actually be where we can develop medications that could hopefully interfere. Now, I'll go through some of them bombed out, some of them seem to work. But we also know with coronavirus, with all the inflammation, is that maybe we can have antibodies that we could use that could turn off some of this inflammatory process. And so that's really all these different targets. Things that didn't work out, this protease inhibitor didn't work out, but Pfizer has a protease inhibitor in development that does look like it might be effective against coronavirus. Remdesivir, and this is not really one that really worked out too well, antiviral. Hydroxychloroquine is one of these drugs that always are trying to find a new use for it. It didn't work for coronavirus. I thought was maybe it would change the pH when the virus was what they call endocytosed, brought into the cell kind of binds to receptors and sucks it all in. It didn't work either. So sorry, Trump, you're one other thing that didn't work during your presidency, hydroxychloroquine. Remdesivir is an interesting drug. Remdesivir is actually an antiviral. And this just goes to show, I don't, again, expect anybody to be experts at the end of this, but this is how we do drug studies. So remdesivir was compared to a placebo. And what they looked at actually was proportion that recovered from it. It was an NIH trial, and there were some other trials that were done with it. And then they have to look really that these are error bars, each of these blue boxes that you see at the days out. And they really want to see that actually there's a statistically significant difference between treatment, remdesivir, and placebo. And that's what the FDA will look at when they're looking to see maybe is this therapy is effective or not. And what they found with remdesivir is it seemed to be better in those who had severe COVID before intubation. It had to be used really has to be used within the first 7 days. It seems to have some role. It's been kind of disputed sometimes whether it's effective or not. It doesn't seem to help that much if you have more mild or moderate COVID. And it doesn't help if you're too severe. So if you're too far along and you're already on the way to intubation, unfortunately, it doesn't seem to help there. But if you notice, one thing is we don't treat people just remdesivir versus placebo. They're usually getting other therapies now. But we had to start somewhere. We had to try to figure out how this works. So now, often if someone comes in sick, they'll not just get remdesivir, but they'll get other drugs with it. And so they may get monoclonal antibodies, and those also, work the same way. We're looking to see, where we can maybe use them. Maybe we use those monoclonal antibodies to inhibit the binding to that ACE2 receptor. So what happens is these monoclonal antibodies are binding to that the spike protein. We call the spike protein here. And so that spike protein no longer can bind to the ACE2. And so having monoclonals that can bind to many of these variants, that's always the challenge, seems to also help. So when, we got to keep up with the virus. And when I come back to herd immunity, I'll tell you why that's important. But monoclonals seem to be effective also. And then a drug that we've used for a long time, dexamethasone, which is a steroid. In the beginning, we didn't know if steroids would make COVID worse or not, but it seems like in a British study, and we replicated this, that dexamethasone versus usual care showed a statistically significant, this is what we call a p-value, difference in terms of actually improvement. Now, again, if someone comes in severely ill, we're going to probably combine therapies, dexamethasone, remdesivir, if they do need, respiratory therapy, oxygen, we're going to do all those things. But we need to start somewhere. And unfortunately, I had to do treatment versus standard of care, or what we call usual care, because if you threw everything, it's like making your soup in the kitchen. If you just throw everything in the pot, you no longer know what tastes good or tastes bad or whatever. So unfortunately, we had to learn the hard way as to what was effective, what wasn't effective. And I'm not going to go through these, but these are all things how we actually really make sense of the data, how we really look at things that are actually effective or not. And just to give you a rundown, if it's less than 1.0 in relative risk and relative risk of mortality, it is showing that something is effective. And then we look at a statistical value called the p-value to really see how statistically different that is. And so when we see these things showing up here, and these are what we call confidence intervals, that's how we can actually make heads or tails of whether something works or doesn't work. Because otherwise, we don't know what the hell we're doing, and we really can't tell you if a therapy works or not. And you can see, just for example, no oxygen with dexamethasone versus no oxygen in usual care, it didn't help. So oxygen has got to be part of the whole mix when you're using dexamethasone. And this was used in people who had severe COVID, again, low oxygen levels. Again, going back to what can you do to decrease the risk of COVID? So, they were saying scrub your fingers and, sing the happy birthday song. It's not so easy just rubbing your fingers. I'm not sure it'll come through on camera, but you want to do is soap up. Soap's important because, again, that fatty lipid bilayer of the cells, it's disrupted by soap. So you want to rub your hands together, keep your nails short because you don't want to have gunk and gook under your nails and have COVID there. You want to rub your fingers together. You want to make sure you get your thumbs, get the back of your hands, and really kind of do this. Warm water, doesn't have to be hot, but warm water is better than cold water. And then you want to dry it well. And you want to do this, especially before you eat, before you touch your face, those kind of things. So, quick rinse without soap, without water doesn't count. You remember the debate in the beginning, do masks work, not work? Some people, go back to this whole thing with masks, but we saw that actually mask mandates associated with large declines in COVID. The masks do work when they're worn the right way. And you can imagine how hard it is to actually do a mask study if people are wearing masks, as chin straps or as yarmulkes instead of over their nose and mouth. So, but if a mask is really worn correctly, and it probably doesn't even matter too much, what the mask is. You just want to cut down on that spread of those large droplets. And if both people are wearing masks, the person who has COVID and the person who potentially be infected, again, it probably cuts it down by 95%. So, and other things that were done to really, effectively cut down on COVID was decrease the gatherings, the size of the gatherings. We don't want 25 people packed into a small room and people coughing and spreading COVID to each other. So, so we cut down on all those things. And stay home if you're sick. Just some basic advice, wash your hands. Remember, we tell people sneeze into your elbow. Well, that's probably not going to be enough. You want to really kind of just not go around anybody, avoid close contact with coworkers and customers, avoid shaking hands and washing hands and physical contact. So stop shaking hands. So that's probably a convention that's seen better days. We're probably not going to be shaking hands with each other for a long time. I'm going to switch gears and talk about vaccine. Vaccines are the way for us to really get out of this mess. And we've seen that. We can do mask mandates and social distancing or whatever, but it comes at a tremendous cost. And we're human beings, and human beings like to socialize. And so to live, in this separated states, it's been under tremendous strain for so many individuals, and it's just not sustainable. The way we get out of this is really, if you think about it, it's fascinating, is that we teach our bodies to actually recognize that a protein, in this case, a portion of the spike protein, and say, gee, that shouldn't be in us. And if we see anything more than that, our body needs to be primed and ready to knock it out and block it from binding to those ACE2 receptors. And that's how vaccines work, is in this case for the coronavirus. I'm going to skip over that. Vaccines prevent diseases that can be dangerous or even deadly. They work with your body's natural defenses to safely develop protection from a disease. It helps your immune system produce antibodies, just like it would if you were exposed. This is what makes vaccines such powerful medicine. Unlike most medicines which treat or cure disease, vaccines prevent them. COVID vaccine will help you keep from getting sick. We're fortunate, unbelievably fortunate. When the vaccine was available, I was first online to get it. I'd seen way too much COVID and didn't want to run the risk of getting it. The more people who get vaccinated, the faster we can get back to our normal lives. So let me talk to you a little bit about what herd immunity is, and then maybe why vaccines are so important. I think of herd immunity the way you think of a forest fire. A fire burns if it has wood, trees, to burn. What a vaccine does is it takes away the firewood, and that fire can't spread. So COVID is the fire. We unfortunately are the trees and the forest. But if we're vaccinated, COVID finds us. Our bodies are primed and ready. And can you still get COVID if you're vaccinated? Yes. Who's more likely to get COVID and sick with COVID if they're vaccinated? It's people who have those underlying conditions. It's not 100% rule, but it's more likely. But we've seen, and you see this now in Israel, is that enough people are vaccinated, even being vaccinated cuts down tremendously COVID infection. And if enough of us get vaccinated, that forest fire can't spread very far. And so we're not only just protecting ourselves, we're protecting all those people that we come in contact with. And the other thing we've seen is that people who are vaccinated, if they do get COVID, their viral burden, the amount of virus they have, is much, much, much lower than if they weren't vaccinated at all. Now, the big reason also to get vaccinated is that viruses need host people to replicate. And unfortunately, an RNA virus, without getting too technical, they like to make mistakes, mutants, variants. They call them variants, but they're mutants. Viruses will change. They evolve, and they can evolve very quickly. And they evolve very quickly because of some of the some of the things that your cells have is called a proofreading mechanism, which your cells want to make similar cells. Your heart cell doesn't want to make crazy cells. That becomes cancer. That's what cancer is. So it tries to make the same blueprint over and over again. Viruses don't really care too much. They want to make more baby virus, but they don't have that proofreading mechanism. And so then they start making virus that's a little bit different than the parent. So those viruses that become a little bit different, well, some of them don't mean much, but some of them actually become more infectious, more likely to be transmitted, more likely to replicate, more likely from one person to spread it to, instead of 3 or 4, maybe 5 or 6 people. And that's what we don't want to have happen. And the way to stop that spread, yes, wear a mask, social distance, wash your hands. But if your immune system is primed and ready to not get infected, that's really huge. Then you really stop the spread of the virus. And that's why that's what's called herd immunity. Weak enough of us actually are immune to the virus. It has nowhere to go. And that's when that curve really will come down. Now, you can see that Jersey has done a great job. Our vaccination rates here are tremendous. But that's what has to be replicated here and all over the world. As long as this virus is still going to be replicating, it's going to be changing. And that will dictate the long term as to how often do you need to get revaccinated. And that's going to be predicated on 2 things. It's going to be predicated on how long does our immunity last, or antibodies last from that vaccine group that we got in the beginning. But it also comes down to how well our vaccines keep up with the virus that's changing. And again, the virus can't change unless it can actually infect somebody and replicate, multiply. So those are the keys. That's why all this stuff becomes important. Is we got to think of ourselves, but we got to think about those people who've been reluctant to get vaccinated. This is a miracle. The COVID-19 is funny to say miracle in front of a temple audience, but this is a miracle because the reason, this technology was being worked on for a long time. It didn't just spring out of the blue. We just didn't know where it was going to be used. But the miracle about it is that this vaccine, at least Pfizer and Moderna ones, I'll tell you a little bit what the vaccines are. It uses mRNA, so that positive strand RNA, whatever I said before, it's really instructions. And what those instructions are doing is they tell your cells how to make something, how to make a protein, like a blueprint that tells us how to make the sukkah. And so it's telling your cells, you just need to make this little portion of the spike protein. And then after that, your body's going to do the rest, because when it sees that little portion of spike protein, it's going to then say, hey, that's something new and different that shouldn't be in us. And you make your antibodies to it. And that antibody response, that immune response, is why maybe after the vaccine you feel achy or sore or fatigued or run down. Your body's making an immune response. That's what happens with vaccines. What's a miracle about this is that if we just put the RNA into you without anything else, your body would destroy it. The RNA is not very stable. That's why it has to be refrigerated. What the folks at Pfizer and Moderna figured out was how to take that RNA, and the miracle of it is put it into a fatty, almost like replicating a lipid, a viral particle, like a lipid bilayer around it, and then to be able to vaccinate it and your cells to recognize it and take it up and then make that little portion of the spike protein. It's really unbelievable that they were able to do this and do this as quickly. And what's also important with an RNA vaccine is that the vaccine makers can change that quickly. They can modify it so if there are variants that have to be taken into account, they know the genetic sequence and they can start changing the vaccine formula, the RNA formula, to keep up with what variants need to be treated in case they see that the vaccines that we're getting now are not keeping it, that we currently got, do not actually work against them. It looks like so far the first round of vaccines do have quite a lot of effect against these variants, the Delta variants and whatever. So far so good. The J&J vaccine uses what's called an adenovirus vector. An adenovirus is a totally different virus. It's a DNA virus. I don't want to get too far off into all these things. And what they've done is they, again, inserted some of the instructions into the DNA of this J&J virus to, again, go from DNA to RNA to tell your body to make a little bit of the spike protein. Adenoviruses maybe cause some of the inflammatory reaction, maybe cause some of that, those rare cases of the blood clots in the brain that you may have heard about. So, it's a different thing. It looks like the J&J is nice, is it's one shot. It doesn't have to be so highly refrigerated, but there's not head-to-head studies of these different vaccines one against the other. But it looks like maybe the RNA viruses give you a better immune response. So, it's 2 shots, but I think it's worth the 2 shots. But it's amazing, they're all really effective, and getting any of them will really help curb infections. Now, the other day, a new vaccine was approved by a company called Novavax. They're a really small startup that got a lot of money from the government to develop a protein-related vaccine. And so what they do is, it's kind of like the technology you use for like your tetanus shot, is they take up just the protein and they basically inject that as a vaccine, and your body makes directly the antibodies against the protein. So they've skipped all the steps of instructions and RNA and whatever, but they've gone right to it. The important thing with all of these vaccines is nothing gets into your DNA. And so the common questions I hear from people is, oh, I don't want to take the vaccine because it's going to get into my DNA. It doesn't. That's not how they work. You make the instructions are there, you make the protein, and then the instructions are destroyed and it's gone. It's not getting into DNA. I've had people say, oh, there was a common myth going around that it's going to make people infertile. They won't have children. And this was a huge thing going on, and it's still going on in Borough Park in the Orthodox community and in Israel. And they had to actively counter this in Israel to get people vaccinated, especially in the Orthodox community. And it was really interesting what they did there, because people would get on these phone banks, get messages, and the phone banks are being paid by how many people listen to it and say, don't take the vaccine, it's going to harm you from having children. Of course, fertility is extremely important in the Orthodox community. And, and they're hearing this and they're not wanting to get vaccinated. And so they had a campaign, basically whatever these phone banks was, to put them out of business. And whenever posters went up in Israel in different areas, don't get vaccinated, they'd have people going immediately over the poster saying reasons to get vaccinated. And they tried to get the rabbis as much as possible to, again, reinforce the message. And but one of the most effective things that happened, unfortunately, was a young woman pregnant with her 5th child said that she was going to get vaccinated. She didn't get vaccinated, and she died from COVID and lost the baby in the process. And again, the anti-vaxxers tried to say, oh, see, the COVID vaccine killed her. And then her husband came out and said, no, she was never vaccinated. She died from COVID. And, he's left with 4 children. And then when other young women heard this, it really kind of convinced them. They said, no, we really need to get vaccinated. And that really helped turn the tide from especially many of the young women there who wanted to get pregnant. And there was an article in the Times a few days ago, still again, Brooklyn, how a couple of the rabbis one has their brothers, one has 12 kids, one has 13 kids, and they're still telling people not to get vaccinated. Humans shouldn't be guinea pigs and shouldn't be taking vaccines. And unfortunately, it's impacting and if you look in the vaccination rates in different groups, in the ultra-Orthodox communities in Brooklyn are among the lowest in terms of vaccination rates. And it really takes a lot of efforts to really counter this. It's a lot of misinformation and very destructive misinformation. I'm going to skip over some of this. This just tells you a lot of things I just told you is how we actually look at these. One of the very important things with vaccines and new technology is to be very open and frank and out about how things go and when things are reported, to get them out there. So now you may have heard that there's been reports of young men, especially under the age of 40, developing a rare condition called myocarditis and inflammation of the heart after getting vaccinated. It's a problem. These are not very common. If you look in the course of the millions and millions of people that have been vaccinated, very few have developed, any of these things of blood clots or the inflammation. But it's something to recognize and to know that there are risks and benefits of these vaccines. But again, it's true of everything, and everything that we do, there's risk and benefits of everything. And I think you have to really weigh it out. And For me, definitely the risk of COVID is so much worse than the risk I would take from, potentially from a vaccine. So it doesn't take much for me to feel that, vaccination is definitely the way to go. This just gives you an idea of the timeline of how vaccines are usually developed. They go through research, usually it's animal research, initial development, then there'll be testing, and then the manufacturing occurs. And then if everything looks good during the process, I'm sorry, this is the COVID vaccine. It goes through testing, and then if everything looks good, it goes through approval, and then it's the ramp up, and then it's delivery. Now, if we did this with COVID, right now, we would be still awful in terms of infections. So one of the things they did that was smart was they said, listen, we're going to hedge our bets. We're going to ramp up the manufacturing development, pump money into the companies to actually get things ready. So if their vaccine looks good and gets approved, they're ready to hit the ground running. And that's how we were able to speed up this timeline. Otherwise, it would have taken another, I would say, probably 2 years before these vaccines would have been out. This I've already talked about what an mRNA vaccine is, but it's really just taking a portion of the instructions that it's not even taken from the coronavirus. It's just, we know the sequence, putting it into a fatty layer, and then that's what you're injecting into your body, and you just make a little bit of this protein, the spike protein. I'm making the whole thing, and then your body says, hey, that's not normal, and you make antibodies against it. And then if you get the real thing, you're primed and ready to block infection. You cannot give someone COVID-19 from getting these RNA vaccines. It's not going to give you it. That's what I've heard also. It's a lot of garbage and junk on Facebook and TikTok. Sometimes my patients will come in, they'll show me, look at what I saw on TikTok. And it'll be like Jesse Ventura, I'm not kidding, interviewing somebody who's saying those. And I go, do you really think a doctor who's worth their salt is going to go on TikTok to give medical advice? Come on. Vaccines that we're using do not contain live virus. Now, the Chinese have a vaccine that uses killed COVID-19. It hasn't been well studied, but it's being used around the world. I kind of don't trust it, to tell you the truth. Serious side effects from vaccines, including COVID-19, are rare. They really are rare. And these are the most common things: tiredness, headache, pain at the injection site, chills, nausea, vomiting, fever. It was important in vaccines, especially this one, to study it in men and women, and to study in different populations and ethnicities, because if it was just studying a white population, which unfortunately a lot of the studies that are done end up being that way, then how do you get buy-in from other ethnic groups? And how do you know that actually what we see in one group is the same that we'll see in other different groups? Because we know, as similar as people are, there are some genetic differences that may predispose some groups to a different reaction to them. So they purposely really engaged groups to be involved, and it has to overcome a lot of biases. There are a lot of groups that feel very kind of threatened, especially after the last 4 years of the presidency. It's like, if I'm not documented and I involved in one of these trials, am I going to get deported? Or is this some I've seen people where they're approached about even getting vaccinated, and they're saying, well, why are you targeting me? What is this all about? Maybe there's something in it. And you may have seen all the nonsense about maybe there's a microchip or something in there. I always tell people, the microchips in your phone, the microchips in your credit card, microchips on everything you do on the internet, that's where the microchip is. So the Moderna vaccine, the same thing, was tested in white, Hispanic, Black, and Asian, and they purposely went to enroll enough individuals in these different groups to have real data to show that actually it's effective in all these different groups. And now, the original group was 18 and above. For Moderna, it was 16 and above for Pfizer, but you can see now we're looking at, we have data now to support using it in 12 and above, and we'll have eventually data to use in ages 5 and above, and I'm sure we're going to go lower than that. J&J, the same thing, used in different groups. Dark color means the study participants, randomized to, the vaccine is a lighter color, and doing these studies, in all over the world to show that actually, their data that we see is really robust and global. People talk sometimes, I can't take the vaccine because I have allergy. I eat raspberries and I break out. Well, it's really if you have a vaccine allergy to any of the ingredients in the vaccine. And so for the RNA vaccines especially, it's probably if you have a polyethylene glycol allergy. Vaccines do not contain eggs, gelatin, preservatives, or latex. So the full ingredients, you can go online and see what they are. But if you have a really severe allergy history that's not, that's like, something where you're really concerned, definitely want to talk to your doctor. And people who really have these severe allergic reactions to things like bee stings or whatever, probably do want to have an EpiPen ready, if they get vaccinated. But I would say, have a long conversation with your doctor, make sure that it's okay to do. I had a lot of folks that were very hesitant to take it because they had a penicillin allergy or, an allergy to, nuts or whatever. And I had to tell them, you're going to be okay. It's not related to the vaccine and you'll be fine. Or they told me they had a allergy to eggs. No, you'll be fine. This is not prepared that way. And I think, our vaccine preparation for other things is going to change because of what we've learned from making COVID vaccine. We've really been outdated. People say it was made too fast. No, we were making vaccines too slow and using very outdated technology. I'd like to have a baby one day. Is it safe for me to get COVID-19 vaccine? Yes, people who are trying to become pregnant now or plan to try in the future may receive the vaccine. My wife's sister is a new grandma. She has has twin daughters who both were pregnant around the same time, and they got vaccinated during the pregnancy, and both babies are fine, healthy, and bubbly, and all those kind of good things, and nothing harmed the mom, and nothing harmed the baby. Maybe if anything, they've seen actually his mom might pass antibodies to the baby that could protect the babies from COVID-19. This is just those articles I was telling you about in the New York Times last week. Why do some Orthodox Jewish women won't get vaccinated? I'm just going to read a little bit from it. So this is an 18-year-old Miriam Toole from the Crown Heights neighborhood of Brooklyn said the rumors influenced her decision not to go to Israel for a one-year stay at seminary in Jerusalem because it required vaccinations. So she didn't want to go to Israel because they were requiring vaccination. And then this was some of the information that was being given out by Rabbi Green and his twin brother, Rabbi Daniel Green, a Hasidic rabbi who lives in Crown Heights, directs efforts to resist the vaccine in New York City. He recently stepped down from his teaching position at a local seminary for post-high school Hasidic women because the school hosted a clinic to administer COVID vaccine earlier this month. The Green brothers believe that Jewish law forbids someone to expose him or himself to an experimental vaccine with those of childbearing age poised to lose the most. And then this is what I was telling you about in Israel was the story of unfortunately, this guy who lost his wife. The wife's a really unfortunate one. She died and she lost a baby also. And they had to set this straight. Conspiracy theorists took advantage of their story. They decided to fight us, and it was like an organized army. They were claimed that my wife was vaccinated, and therefore she died. Yehuda ben Shitrit, my Hebrew's terrible. 30 says, it was like they were twisting a knife in our stomach. The family set the record straight in interviews with ultra-Orthodox and mainstream media. They emphasized that his wife Asnat had not been vaccinated. If she had been, she could have lived. A relative told Israeli public broadcasting he had been monitoring his own anti-vaccine group on social media and shut it down after Asnat's death. So the American College of OBGYN says get vaccinated. We do know that getting sick with COVID during pregnancy can increase the risk of severe illness and may increase the risk of outcomes like preterm birth. So the recommendation is get vaccinated. Pfizer vaccine is authorized for people older than age 12. Moderna and J&J are authorized for people older than age 18. And like someone said, these things are changing pretty quickly. So, when you vaccinate, don't be surprised if by the time I finish this, they'll have new guidelines and new approvals. Will a COVID vaccine change my DNA? Sometimes I'd like to change my DNA, but the COVID vaccine won't do that for me. So COVID-19 does not change or interact with your DNA in any way. Vaccines teach our immune system how to fight against a specific virus. In order to do its job, the COVID-19 vaccine doesn't need to get inside the nucleus of our cell, which is where our DNA lives, or is kept. I shouldn't say lives, but is kept. This means the vaccine never interacts with your DNA in any way and has no way to change it. How long after getting the vaccine does it take to be effective? So usually with the RNA vaccines, you are going to have an antibody response after the first shot, but you're not fully immune, really, with really high antibody titers until after the second vaccine shot with the two RNA vaccines, the Moderna and the Pfizer. For the J&J vaccine, it's probably about a month afterwards before you have full on protective antibody response. So it takes about a month. So those Yankee coaches and all, we learned a few things from them. First, it was like 9 or 10 of them that got COVID. And the only new reason we knew they had COVID was because the ball players are getting tested all the time. They had received the J&J vaccine, but they really didn't have, they were asymptomatic. They didn't have much virus that was, present when they, checked them for it. So the vaccine worked really in terms of mild symptoms, but it was that they got COVID too soon after being vaccinated. That was the issue. So probably a month after, if they'd, been isolating, wearing their mask, keeping out of touch for, a good month after the vaccination, they've probably been fine. But we saw that actually they didn't get that sick anyway. I think one had some symptoms, was mild. Do I need to keep wearing my mask if I'm fully vaccinated? Yes, until more people are vaccinated, some prevention measures will continue to be necessary. And this is Bob's question. It's like, if you're vaccinated, you stop wearing your mask, are you going to transmit? Again, the vaccines will keep you from getting severe COVID, but you could get a mild case of it. And again, all of us are a little different. We may have some predisposing, conditions that could make us, not as have a robust immune system. We might be a little bit older and might be a little different for us. So you could have low level, amounts of virus that you produce. But if you're around groups that haven't been vaccinated, you could spread it, even with low levels, you could spread it to them, and then they could spread it to others. So, that's why, we've said, keep wearing your mask until we get to a certain point of hopefully herd immunity, enough people vaccinated where the virus doesn't have the firewood to light up and catch. The one thing that I had to tell you different in that firewood analogy that I use, fire is the same. It burns the same way in the forest fires. COVID, when it burns as fire, it changes. It starts mutating. That fire takes on little different effects as it goes along. And that's the problem. We don't want mutating virus. We don't want it changing. We really want our vaccine to be robust and work against it for a long, long time. And the way is to stop it from multiplying. This is just thought questions, but I'm going to stop here so people can ask questions, or if there's things in the chat box. But these are just some thought questions. If people didn't have anything else they want to ask.
Let me say thank you, first of all, Julia. This 16 months has been something that we've all been riding on the outskirts, and you've been in the midst of this, and what you've given a sense of is the incredible amount of learning that's gone on over the last 16 months. And what's also incredible is you were able to squeeze that into an hour for us tonight. Yeah, you did agree to take questions. I'd say if you want to, I'll call on people, because with Zoom, we can't speak at the same time. Raise your hand, either actually or the virtual hand. I would suggest, though, that we have our questions about the science. I don't want to put Jason on the spot to answer questions of policy. What should New Jersey do? What should Temple Israel do? What should my Aunt Belle and Uncle Joe do for the party they're having next week at their house? We can keep the questions general on the science. If Dr. Leider wants to express an opinion, it's his night, so he can say what he wants.
Here I'm Jason. I'm not doctor at home.
Okay. Right. That way it's not an official position. Eric Weiss, go ahead.
Oh, he might be on mute.
We don't hear you, Eric.
Hear me now?
Yeah.
Yes, go ahead.
All right. Thank you, Jason, for a really great presentation. I have some questions based on, I listened to Dr. Fauci about 2 weeks ago. It was a relatively small group because my college had honored him. And he talked about, he called them two things that keep him up at night. And I want to get your opinion on what he said. He said, first of all, the global situation keeps him up at night because the global pandemic, the lack of vaccines in other countries will allow the vaccine to cook and to mutate, and variants, Delta, Gamma, Epsilon, blah, blah. And he said that the fact that it will continue to mutate it will continue to become more efficient at replicating itself. That keeps him up at night. Let me give my second question, and then you can answer both of them. He said the other thing that keeps him up at night is the that immunity. It looks like the immunity from present vaccines will last 8 to 12 months. That was his statement to us 2 weeks ago. And he said, therefore, everyone will need a booster shot in 8 to 12 months, which, you know, I was vaccinated in March or April, which means December, I need to get a booster. So will those boosters be available? So would you comment on what he told us at that point? Thanks for taking my question.
Yeah, thank you, Eric. I mean, I think he's right on both of those. I think that, and that's how we have to look at it, is that, you know, we will not be able to live in a vaccine bubble here while the virus continues to go on elsewhere. And we've seen how fast this can be introduced into communities and take off. And again, viruses, especially, you know, and like an RNA virus, they're going to change, they're going to mutate, and, you know, and they're going to look to become more efficient at transmission and replication. I mean, this is, you know, the stronger it's like the Iron Dome of Israel, right? It's pretty good. They made it better, got better, but there's always going to be, unfortunately, something that gets through it. So you want to do is, okay, maybe the better defense is not to have the bomb sent at all. And the way we can stop those bombs being sent at all is if we can get vaccine out to the rest of the world so that the virus is not growing and changing there. So that's going to be the big issue. Now, the problem with the RNA viruses, again, is that they have to be refrigerated. So you can think about trying to send this to tropical and you know, these hot climates or places that really are resource strapped in terms of they're not going to have the money to have ultra refrigerators and things like this. So having stable vaccines like the Novavax, which is a protein-related vaccine, that doesn't have to be so highly refrigerated. So that's these are going to be the important things. And we'll have more and more vaccines that will come out, and that's why we need them and need them to be distributed. Because he's right, replicating virus is not a good thing to have, and we might be lucky if it's 8 to 12 months between vaccine shots, but we don't want to have to live that way to constantly be, you know, vaccinated, revaccinated. And we can do this. I mean, this is how we beat polio. This is how we beat other things, is that, you know, we used our heads, you know, we said, look, this is the thing you have to do. Or they can do it the hard way, which is, you know, you won't be able to do certain activities, whether it's go to college or go to school or whatever, unless you're vaccinated, or even work in certain jobs. And you've seen some of these cases now going up, you know, for the EEO about, you know, hospital workers that didn't want to get vaccinated in Houston. So I think he's right about both of those things.
Let me add to.
Yeah.
Sorry, go ahead.
Yeah, so replicating virus in the rest of the world, bad for lots of different reasons. And you can also know the healthcare systems in those places just can't keep up with it. And you saw that in India, what happened. You know, that's a disaster, right? People, we don't even know how big the disaster is. And then it's going to be, you know, how durable these vaccines are. They'll be improved like everything else, you know, whatever we have now. This is the first go around. They'll find ways to maybe make the immune response longer, but we don't want to have to be in that game. And the best way to be out of that game is to not have circulating virus.
Thanks. I'll read two questions from the chat. One from Sharon Masenkas is asking, when the vaccines are okayed for younger children, how long do you think parents should wait to make sure the vaccine is safe for their younger children? And another question from Linda Schenker, also about the vaccines. Do you think the technology that spawned the current RNA vaccines will be used in the future to speed up and speed up the approval process for vaccines?
Yeah, I'm going to take the second one first. The answer is yes. And I think that vaccine technology is now going to be used, not just for vaccines, but even for making therapies, not just for COVID, but for other things too. Like this is a game changer in medicine. Our vaccine technology was way too out of date. You know, we would, like for flu, we would do is we'd see what circulating strains there were in the world, and then we would pass the virus through eggs, inactivated, or what we call attenuate, so it wouldn't cause severe illness. That's not the way to go about vaccine development. That takes so much time and labor, and you don't want to have something that long. So this is going to change the technology for not just COVID, but for many, many things that we do. So yeah, RNA vaccines and the technology that's being developed is going to change all these things going forward. In terms of the kids, so this gets into the disclaimer that the rabbi said, listen, everybody has to have their own comfort level. But with that, I can tell you what I told my family with even the first round of vaccines that were developed. Once it goes through that rigorous process, again, I went through this very quickly, I know, but these are thousands and thousands of people. And the reason that you have to have some trust in these kind of things is that at a certain point, they know statistically the power of how many people have to be tested to show something has validity in terms of efficacy, but also in terms of serious side effects. Now as we expand beyond the populations that were originally tested in some of these vaccine trials, we do learn things, because some of these vaccine trials may not have enrolled enough diabetics, or maybe people who had other underlying conditions, or kids. But I'm pretty confident once things go through these vaccine trials, they're ready to be used. And waiting 6 months or more, it's not going to add much in terms of what we're going to learn in terms of efficacy. We may learn a few in terms of the rare side effects, but how is that going to impact us in terms of our decisions? So we find out that 1 in a million cases of central vein thrombosis occurs, with the J&J vaccine. Am I going to stop, not going to get vaccinated because of it? No. Personally, the answer is no, because my chance of having that is the same probably of me, winning the lotto tomorrow. So I think once it goes through FDA and this rigorous approval, and the FDA is a rigorous organization. Once we got rid of the political nonsense, and they got down to their business, and they said they would do this in a non-political way, and they did. I have trust in what they say and what they approve. So.
Thank you. I want to just add to that it's distressing when you show the stories of the vaccine hesitancy and skepticism in the ultra-Orthodox world. I want to state, as our rabbi and a conservative rabbi, that there is no hesitancy in the conservative Jewish world. The Rabbinical Assembly position, which I had the honor of voting for, was unanimously passed by our law committee, says that when there's a vaccine, and any pandemic, and certainly this one, that is medically advised, and when one is able and medically able to have it, assuming one doesn't have a condition like a severe allergy, and when it is available, there's a religious obligation to have the vaccine to protect ourselves and everyone around us. Bob Smolin, I saw your hand. Sorry, Bob Smolin.
Quickly,
go ahead, Jason.
Things about the kids. Again, anybody who's infected, unfortunately, can spread it to someone else. And so you got to worry about kids who maybe, visit somebody who didn't get vaccinated. That's bad, right? So that kid who wasn't vaccinated because the parents wanted to wait that extra 6 months or whatever, that's not good. But the other thing too is that we've seen, it's not very common, but kids get this multi-inflammatory system reaction sometimes to COVID. We've seen kids, in terms of deaths and whatever, is much, much lower. But we've seen these cases of these weird multi-inflammatory system reactions. They can be really, really severe in children. So it's not that kids can't get COVID and can't get severe COVID. And I would, once it goes through a rigorous process of FDA evaluation and approval, I'm confident to use it.
Bob Smolin.
Jason, first of all, I wanted to say thank you for putting on an exceptional presentation. It's a pretty high bar you bring to the table, and I was very impressed on a personal level. And thank you on behalf of the synagogue. My question, it was exceptional. My question, I was in North Carolina a week ago, and you go around there and it's like the pandemic never existed. And of course, with the governors and from each state now lifting all mask mandates and pretty much open season, should we be, you presented more of a conservative point of view of that. And I certainly understand that you've been in the thick of this which I can't even possibly understand that you've had to go through. But you know, in your continuing to encourage us to wear masks, whatever, in a society that is getting rid of them or is using the position of if you've been vaccinated, you don't need to wear it, seems to be a contra behavior. So maybe I'm just asking you to repeat again your position on where should we be, yet the society is bucking the trend.
Yeah. So the most conservative advice would, and I know like this has been so confusing to everybody in terms of what you're seeing, because a lot of things don't make sense that we've seen. You know, you'll see the baseball players or the basketball players, and they're out on the court running and sweating on each other and breathing on each other, and then they go to the sidelines and they're putting their mask on. Sometimes it's not mask. Like, what is that doing? I don't even know what that's doing. The truth is that if you've been vaccinated, again, what the vaccination studies showed more than anything was you did not have severe COVID, really uncommon. And when we've seen severe COVID, those that are vaccinated, it's usually because they had a major underlying condition. You know, we have right now in the hospital, for 2 weeks, we had 0 COVID cases, which was the first time we've had that since March of 2020. And now we have 2. One is the person that wasn't vaccinated, and the other person, she got the J&J vaccine. I'm not blaming it on that, but she's 90 years old with multiple comorbidities. So if you're vaccinated, you're not going to get severe COVID, but you might get a mild case. The real concern is like if you have that mild case, again, your levels of virus are going to be lower, but you could spread it to those that are not vaccinated. Now, the problem that we're seeing, you know, unfortunately, as this breaks out, you may have seen that Vermont now hit the 80% at least one shot level. New Jersey is in the 70s, which is outstanding. And it's different based on age groups. Those that are over, I think, 65, it's really, really good. But for those that are not vaccinated, I go through this at work all the time, is like, I don't know what other information besides what we just did to do them, to teach them, to educate them. It's sort of like, I've had some people come in and I'll ask them, do you want to take the vaccine? And the answer is no. And I'll say, well, why? Just no. And they're not giving any material to even educate with when you just shut it down like that. New York Times had a whole thing online about how to try to talk to people about vaccines, just for lay people to talk about it. And so confrontation doesn't work. I still do it, but it doesn't work. But trying to see if there's any kind of common ground that you can find or anything that you can talk about and maybe educate them on would be the way to go. And, and I think that's what's important, is that if it's a worry about fertility or pregnancy, well, we studied it there and it seems to be okay. I think unfortunately what's going to happen in southern states, we're seeing a few things. Some is that it's access to vaccines. So some of those states, unfortunately, there's problems with accessing it. Some of the states, it's just purely distrust of the government. They just don't really think that the government has your best wishes in place. And you may have seen data showing that 25% of the African-American community in the United States has been vaccinated. And some of that's because of access, but some of that's just distrust of the government. And some of that's, buying into that this is a hoax, that this doesn't really exist. Some of it's like saying, you know what, we have a lot more problems in our community than this, and this is not, really going to make that much of a difference. So you see all this different stuff. But at a certain point, and this is what I think really the CDC and President Biden decided to do, is say, look, we have it available. It's there for the taking. But we got to get going again. We can't live in this bubble waiting for everybody to just say, I'm not going to do this. I'm going to catch up. You're going to find out your life's going to be restricted if you don't do it. Colleges are already saying, we're not going to take students who are not vaccinated back. You're going to find, I think it's certain, if you want to go to certain places and whatever, you're going to have to show your electronic vaccine passport in some states at least. Or if you want to go to that restaurant, you're not vaccinated, and we're now going to get rid of social distancing, well, you're taking your chances there. And what they've seen now, the Washington Post had a thing I saw today, among those that are vaccinated, COVID rates are extremely, extremely low. But they're seeing the same levels of COVID among those that are not vaccinated. And so take the vaccine and become immune. Don't take the vaccine, you run the risk of COVID, but somehow, some way, I think we're going to end up at that 70% or more herd immunity, but you don't want to do it through infection. And I think that's what we're going to learn in the South, is that all this bumbling and stumbling and nonsense that's going on, unfortunately, it's gonna catch up to them. And you'll see, like what you saw with measles, before the COVID, is that you're gonna have these mini epidemics of, of clusters of communities. They're seeing that in Missouri now, in 2 communities there where they were anti-vax, and they've had a big outbreak of COVID now. So I think that's what's going to happen is the country's going to reopen. It's not going to stay closed. And, I think there's much more confidence in terms of the vaccines will work. And, like Eric said, we may have to get vaccinated every 8 to 12 months or, slight tweaks in the vaccines that we're using. But we're going to blow ahead. But, get vaccinated or run your risk of getting infection. They've seen one thing is that the carrot works better than the stick. So trying to have a positive reason works a lot better than not. I've seen sometimes where it didn't. Like, you had one patient, he came in, I'm not getting vaccinated. And I said, well, why aren't you getting vaccinated? He said, well, now they're saying if you get vaccinated, they're going to enter you into a lotto so you can win money. And so that's got to be bad. And I said, no. I said, what that shows is that they're so desperate to try to get through to people that they're willing to try anything. So sometimes, these things take on a life of their own, and it's important to give some context.
I worry that people are hedging their bets now because the more they wait, the better the rewards are getting. That's
good.
James Goldfarb had his hand. Go ahead, James. I don't hear you. James, I can't hear you.
Rabbi, I guess we have to scrap that idea of offering monetary payments to attention bot services. People will get the impression. Probably not good for you to do it anyways if you're not incented. I did not have a question. I think I was clapping my hands in support of Bob's thanks to Dr. Leider.
Thank you, James.
Any other questions? Well,
I just have a comment, and it's Eric speaking. Can you hear me? James, check the chat about the incentive that'll work for me. Okay. So,
yeah, by the way, I don't have to incentivize the rabbi, but if I had to, that would do it.
Great.
Okay. A private joke. So here's the last question, Jason. It was an incredibly excellent presentation.
Thank you, Eric.
In terms of its factual nature and its brevity, and I wonder if you can share that PowerPoint.
Oh yeah.
Personally, I can use it because I have in my business I need to come up with a masking. The masking policy we've used is wear a mask, and now I'm seeing people in our business environment not wearing masks. I don't want confrontations. I want to try to issue a policy. Here's the policy based on the science. So that's why I'm looking for your presentation.
Sure.